etanercept in this case to the course of immunosuppression with cyclophosphamide didn't add any benefits, and in fact, the patients that received TNF blockade plus cyclophosphamide develop more cancer. So there's a concern with mixing cyclophosphamide and TNF inhibition.
I think we're good. Is there anything else that you would include in treatment?
So what about renal transplantation and outcome after that? Is that something to include or probably not?
I don't know. I don't have anything prepared. Do you have something you want to say?
No.
We can put
Let's leave it out.
Okay, that's fine. All right.
Just give us a second. You found out what that was.
It was the battery was dying.
Oh, okay, cool.
All right, so we're done with this section. So let's use our legs. Get up, walk around. They're going to change the color.
Change the
background
back. Okay.
color, and then we're coming back, do the two cases.
They're going to put a neutrophil in the back. Mine first? Or which one we do first?
Oh, yours rolling?
We'll do yours first. We'll do yours.
Okay.
Sleep.
So I brought a case for you to discuss. This is a 60-year-old male who has a past medical history of high blood cholesterol and allergic rhinosinusitis, who is in good health until he develops a variety of clinical manifestations. First of all, he started complaining of some constitutional symptoms, fatigue, low-grade fevers, anorexia. He then developed some joint pain. He described them as migratory.
Can we bring you guys all closer?
A little closer together, if you were closer together. And Sebastian, we're in a picture tag too. The camera. It keeps moving over, and we want you to look very handsome.
That's it? Okay.
And just a reminder that this is your camera here.
Okay.
Yeah. That's fine with you?
All right. So I brought a case to discuss with you today. This is a 60-year-old gentleman with a past medical history of...
You start that over because they was talking. Just
Ah,
to make
sorry.
sure that was clear.
So I will present you the following case. This is a 60-year-old male with a past medical history of dyslipidemia and allergic rhinosinusitis, who is in his usual state of health until he develops a constellation of clinical manifestations. Initially, he reports constitutional symptoms, fatigue, anorexia, low-grade fever, and soon after he develops migratory joint pain. He says either one knee or an ankle or a wrist would hurt without obvious swelling but pain, probably worse in the morning with some stiffness. And then he develops or he adds some upper airway symptoms. He reports epistaxis, congestion, purulent rhinorrhea. So he presents to the PCP. The PCP orders a series of routine labs, CBC. He does an X-ray of the sinuses. He receives antibiotics, but there's no response. So that prompted the referral to a rheumatologist. Of course, when the patient comes with this upper airway disease, one of the first suspicion we have is GPA, and that kind of streamlined the workup that followed. This patient underwent some extra labs, demonstrated increased inflammatory markers. With the concern of renal involvement, we check renal function, a UA, that fortunately were within normal limits. And then we check an ANCA, and as expected, came with a cytoplasmic pattern and very, very high titers of PR3 antibodies in the 20,000 units per milliliter. It's getting a bit boring, so what?
So how did you treat it?
Okay.
So at that point, what were you thinking?
So we could easily confirm that the disease was GPA. Fortunately, this is not one of these severe patients that you may see in the ICU. There was no kidney involvement. We did an X-ray of the lungs. There were no nodules. We did a CT of the sinuses just to be thorough, and we found, remember, he had a history of allergic rhinosinusitis, but we could see extensive sinus mucosal thickening and some opacification of some of the sinuses. And then that put together, clinical presentation, positive ANCA, no alternative explanation, demonstrated that the patient has GPA. This is one of the examples where we felt that biopsy was not necessary. The picture was very clear. So in terms of treatment,
Sorry.
yeah,
You guys can interact with each other. It's okay.
so I go
So
ahead
in
with
terms
treatment.
of treatment,
So we treated this patient with steroids initially. The patient was, although there was not severe manifestation, the patient was losing some weight and he was very symptomatic, so he was started at 60 milligrams of prednisone. He quickly entered remission. Within a couple of weeks, the symptoms dissipated. And then with the concern of more severe manifestations down the road, we added cyclophosphamide, oral cyclophosphamide, for 3 months until we felt that the remission was induced properly. And then he was switched to a less intensity maintenance of remission with azathioprine.
So, Charles, you mentioned before that a biopsy in this scenario is unlikely to be that high yield. But let's pretend the patient did, for some reason, go for biopsy. Could you discuss what those findings would be if it were able to reflect the disease, the underlying pathology?
So were there ulcers with crusting, or was the mucosal surface intact?
There was some erythema and some superficial erosions.
So probably what would have been seen would be a mix of acute and chronic inflammation. In the small venules, there might actually be quite a bit of margination and diapedesis, but if there was no actual destruction of those small vessels, that really doesn't indicate there's a true vasculitis there, just intense inflammation. At the areas of ulceration, of course, there's going to be superficial necrosis. There may be some fibrinoid material there, but that's different from the fibrinoid necrosis that's so helpful in some other sites to diagnose lesions consistent with ANCA vasculitis. So it probably would be a relatively small biopsy, and so the diagnosis would have come back just nonspecific acute and chronic inflammation, maybe with ulceration. The problem can arise in other settings when it's not ANCA disease and not vasculitis, if that intense margination and diapedesis is misinterpreted as vasculitis. But again, in this circumstance, I doubt you would have found true vasculitis. Although having said that, on a minority of specimens like that, you will find small vessel fibrinoid necrosis and inflammation, and you can diagnose vasculitis. That's the minority. Also, a minority of cases, there'll be enough architectural preservation, you can actually conclude there's granulomatous inflammation with giant cells. But it's low yield for a definitive diagnosis.
Let me ask you this question. In this case, it's clear that it's GPA, clinical presentation, the ANCA-C with PR3, but we were talking that the differential is broad, and we must mention that EGPA, or the formerly called Church-Strauss, can present sometimes in a similar fashion. And this patient has a history of allergic rhinosinusitis. Can you tell us a few pearls or a few points that help you distinguish GPA from EGPA?
Well, it's difficult because there's so much overlap. If you go strictly by the definition in the so-called Chapel Hill Consensus Conference, there needs to have been a history of asthma, and the patient apparently did not have that, and there needs to be blood eosinophilia, usually 10% or more. Did this patient have blood eosinophilia?
He had a slight hypereosinophilia, but in the hundreds.
Right. So In the absence of those two features, then the appropriate diagnosis by that approach would